Right, it's 10:15. I hope you can hear me. Good morning.
Morning, Doc.
Is,
Morning po,
every-
Doc.
is everyone okay? Okay, so, unfortunately, Dr. Legaspi cannot give this lecture this time for this year. Consolation is he has been using my slides anyway for the past 3 years. So, anyway, I updated the slides so they're more modern. So, today, for this session, we're looking into the blood vessels of the brain. So, very important uh, based on Dr. Dasig's lecture. So the brain really needs blood, a lot of blood at any time. So I already put this on the canvas. So sorry for the busy slide. So just follow the mouse. So after this lecture, you know where the blood flow goes to get into the cerebral hemispheres. And you'll see again another proof that the eyes are extensions of the brain because the eyes blood supply actually come from the same blood supply as the brain. And then on the posterior aspect, you know where the blood flow passes through when it arises from the vertebral basilar circulation to supply the posterior cerebrum, the brainstem, and the spinal cord. Now, you will see something unique to the brain. We have end arteries there. And to get around this limitation of end arteries means it's the end. So the blood there is interrupted, no more blood. But there are ways for the blood flow to get through via alternative routes. So the concept of collaterals. So that later you'll be more familiar, or if this is the very first time you'll be hearing the term circle of Willis, you'll see the significance of the existence of the circle of Willis. Then something often neglected in medical school, which you will be bombarded with, because it's as you can see when you look at Taft Avenue when it rains, no, drainage is very important. So the same thing happens to the brain if the blood is unable to exit. So you get disasters, no? If the blood is unable to exit the cranium via the sinuses and the internal jugular veins. Well, not so much in this lecture. I hope this has been covered by will be covered by Dr. Singh regarding the spinal cord circulation. And a term which you'll be more attuned with as you go along through medical school, you see patients coming out of anesthesia with a stroke. So the concept of watersheds when not enough blood reaches a certain part of the brain. Most of the new pictures in my slides come from the neurosurgical atlas of Dr. Aaron Cohen. So as I mentioned a few slides ago, days ago, wherever there are a lot of there is need for blood, that part of your body is very important. So to emphasize a point, so if you minus out all the brain, the CSF, the dura, and skull, and everything on the 3D model, this is what we have left: a lot of blood vessels. So unlike in your atlases where it's artificially colored blue, so blue is not really what we see in the real life person. It's all red. It's just a matter of darker red versus brighter, lighter red. So this is the cerebral vascular anatomy. Now again, it looks quite overwhelming, as it is. So we'll try to break it down. First, we have the carotid circulation. So the carotid circulation, also known as the anterior circulation. So just follow the mouse cursor. That is your internal carotid artery coming out from the base of the skull to supply the brain over here. So the ICA circulation. In contrast to the posterior circulation or basilar circulation or vertebrovascular circulation, which comes uh, from the spine, it exits and enters the subarachnoid space. You see these two blood vessels here. These are the two vertebral arteries, which join to form this artery, which we have seen earlier in the brainstem. It covers the base of the pons. That's the basilar artery or the basilar artery or basilar artery. So we break it down. So much of what we learned in the way anatomy of the blood vessels are came from angiograms. So this is an angiogram, meaning we inject a material into the vasculature to make it light up on an X-ray. So this is an X-ray, and this is the shadow of the contrast as it enters the anterior circulation by the internal carotid artery. No, if you see what happens here from this singular artery down here, it then explodes to supply almost everything up here in the brain. So at this level, this is the first time we're looking at an angiogram or first time to understand how an angiogram looks like. So from this singular artery, you see it spread out to supply practically the whole lateral surface of the cerebrum, which tells you how important this is. It is that important that it has a lot of blood supply. At the same time, the critical thing here is that's a lot of blood supply to supply with just one artery. So if something goes wrong with this artery, it's a disaster. And this is the disaster. The whole cerebral hemisphere on the right side of this patient has been lost. And when the blood supply is lost, we call that a stroke. So it happens instantaneously. So this is something that you will learn once you see patients, once you go to the LU4, that a sudden loss of blood supply has automatically instantaneous loss of body functions controlled by that side of the brain. So vascular is almost equivalent to rapid, something fast. So if something fast happens to someone that you see at home or on the street or in the hospital, you have to think, is it a vascular event that's going on? So this is a major catastrophic vascular event involving the anterior circulation of this patient. You can see the brain actually crossed over already to the other side from the swelling. So again, we break it down. So angiogram is a way of breaking it down so that we do not get lost or overwhelmed. So we start from here in the neck. So from the common carotid artery or the CCA, a branch will supply the face and everything on the outside so that everything external is supplied by that external carotid artery and everything internal is supplied by that internal carotid artery. So since it doesn't supply anything outside, you do not see any major branches come out of here, and then it branches out once it reaches the subarachnoid space. So we'll get to know all these different branches very, very slowly. So we talk about the ICA, the internal carotid artery. So this is a CT scan angiogram where it's like a graphics editing as far as the radiation technologies is concerned. He has to click, click, click here to subtract out all the extraneous imaging so that we're left here with a reconstruction of the vasculature. So you see here the ICA branching off to go into the skull. So when we look at the ICA, so this is what we call the Cincinnati classification of the branch or the naming of the branches of the ICA. So if it's in the neck, then we don't call it neck ICA, we call it cervical ICA. So the character, I just made a ghost image here to highlight it. So just follow the shape. Here it is unbranched. You don't see any branching out here because it is an internal supplying artery. So it is unbranched within the neck. So that is the first segment, also known as the C1 or the cervical ICA. So once it reaches here, so it has already been subtracted for you, but this is an area of the skull already, which is very hard. So the petrous portion of the temporal bone. So it has to enter into its own eponymous canal, which is the carotid canal, which you would have seen already in Dr. Seng's lectures. Now, once it enters into the bone, it's no longer visible. That's why we need angiograms because it is covered up by bone in this area. So that is the petrous segment of the ICA or the C2, petrous portion of the temporal lobe. So nothing to supply here. It's surrounded by bone. Right? So using pictures from the neurosurgical atlas 3D model. So that's your carotid canal with the ICA inside it. So around that area, it will be invisible to everything else, to everyone else, unless you cut away the bone using digital editing tools in the machine of the CT scanner or the magnetic resonance imaging machine. So in this area, the C2 segment of the ICA is in the bony part of the temporal bone, and the cochlea, which you learned from OS204, is right nearby. Although nothing really happens here, it's protected by skull, right? But then if you're an ENT surgeon or ORL surgeon, you would want to be very careful not to drill too hard here, and then you rupture the ICA. Right? So this is the C2 segment, the invisible segment because it's hidden by bone. So just to orient you, so this is the petrous portion of the bone. You're looking at it from the right side. This is bottom. Up here is the vertex. No? So this is the floor of the skull, and shown dissected away for you to show you the inner ear inside here, and that's the eighth cranial nerve. Okay, so this is a cutaway. So this is actually covered by bone, just to illustrate that C2 is in this area where you do not see it. Because here you see the ICA already entering into the subarachnoid space. So C2 is hidden here until it becomes the so-called lacerum segment. So why is it called the lacerum segment? It is the part of the ICA, the portion of the ICA that lies on top of the foramen lacerum. So the lacerum is not actually a real canal, it's just a groove. But for some reason, they call it still the foramen lacerum. It's actually a groove at the floor, on the floor of the skull. Where is it here when you're looking at the angiogram? So this C1 bends into the skull in C2. And then when it starts to peek out, that's called the C3 or the lacerum segment of the ICA. So going back to that picture earlier, when you start to peek in to the dura of the intracranial compartment, that is the C3 portion of the ICA. So it's now visible on an MRI or a CT scan angiogram because it's no longer covered up by bone. So zooming in, that is the foramen lacerum, and that is the ICA. Therefore, that is the lacerum segment or the third portion of the ICA. It is now no longer within the bone. It is already within the dura, under the dura, and ready to enter the subarachnoid space. So once it penetrates the subarachnoid space, so it now enters dural venous structure known as the cavernous sinus. So once it exits the skull here and goes into the cavernous sinus, it is now called the cavernous segment of the ICA, or the fourth segment, C4. So on this area, we now complete the picture I showed you earlier when I was discussing the brainstem and cranial nerves. So it's found in the medial wall of the cavernous sinus together with the sixth cranial nerve, the abducens. Everything else is plastered to the wall, the lateral wall of the cavernous sinus here. That is your cavernous ICA. Cross-section, angiogram from the side, a lateral view, and a 3D view over here. So orienting you, front is now over here, anterior is over here. This is the foramen magnum, posterior is over here. That is the lacerum segment, and then it becomes the C4 or cavernous segment. It loops on itself. So loops over here. So the loop is now a landmark for a change in the naming of the ICA. So this part is the C4. This is the C3 on the lacerum. Okay. The C4 is inside the dura mater. But the C5, once it loops up and peaks out here, is now the C5. C5 meaning it's already within the subarachnoid space near the optic nerve up here. So this is up orienting you. This is again the front. This is the back. That's the optic nerve on the left, penetrating its optic canal here. So the ophthalmic artery branches out from the IC and follows the cranial nerve 2 into its optic canal. So while we're here, we admire the scenery while we're here. So this part, which is inside the cavernous sinus, is where you see these cranial nerves. So this picture you need to take with a grain of salt, since it's a 3D model. Some structures have moved. So this is the abducens nerve, the sixth, coming from the pontomedullary junction. You follow it here. So for a while, it is very adjacent, very close to the ICA within the cavernous sinus. This is your fourth cranial nerve, which is supposed to be on the lateral wall of the cavernous sinus. And this big thing here is the cranial nerve 3, also supposed to be on the lateral wall of the cavernous sinus. So in this picture, maybe not so anatomically accurate anymore. But this is the cavernous ICA, where the ICA is close to the cranial nerves 3, 6, 4, and the 5, the first division, the ophthalmic division of the trigeminal. So very nicely shown here, the trigeminal ganglion as it's meant to be visualized. So it's like a plexus here. And then you see the V2 just shares a bit of cavernous sinus before exiting this foramen rotundum over here. So back to a neuroanatomical drawing, that's the ICA, and this is the cavernous segment anytime it is close to the 3, 4, V1, and the 6th cranial nerve. So the bend, cavernous becoming C5 over here. The C5. And just for emphasis again, the trigeminal, the trochlear, and the oculomotor is not shown on this picture. All right, so here we are again. So the moment it gives off that ophthalmic artery, that's the time it changes its name again. It's why this becomes the 6th segment of the ICA. Okay. So after being a dural structure here, it becomes a subarachnoid structure here in the C5, becoming a what we call the C6. C6 when there's an ophthalmic artery coming out of it already. Until it terminates here. The moment it starts to branch into the major cerebral branches, that is the end of the ICA because it will become smaller in caliber and become what we know as the middle cerebral artery. So while we're here admiring the view, now at your level, we don't need to name all these branches here, no, but see what they do. They communicate with the other ICA here. So for med students, maybe for residents, not so we can just gloss over it, but this becomes critical when the ICA is clogged up here by a blood clot or so much cholesterol, so that you need to get your blood from somewhere else. Now, the importance of getting blood from somewhere else is not as important when you're talking about the other organ systems, but when it comes to the brain, we'll take whatever blood we can get from anywhere. No? So these branches that we see here, I will not name them. They communicate with the other side, and they will communicate with branches coming from the face. The facial artery, which comes from the external carotid artery. So you can see how small they are. When you have no problem, it's okay to be small. But once there's a clog here, this will connect with your external carotid artery branches and become bigger and derive somewhat a little bit of blood supply instead of nothing at all, which is important for the brain. So that segment where we give off the ophthalmic artery is called the ophthalmic segment, or the C6. All right, C6. So this supraclinoid is just a terminology, meaning it's no longer near the sella turcica. So the part which is near the sella or the pituitary gland happens to be called the C5 or the clinoid segment. That means if it's easier for you to remember, just use the numbers. No? So they're all based on anatomical regions. So ophthalmic gives away its blood supply. So it gives off the ophthalmic artery, which is critical for supplying the eyeballs. So it exits the skull the same way the optic nerve does. Right, so I already highlighted it here. This artery here, which branches out from the ICA and does not supply the brain, but supplies the eyeball, is the ophthalmic artery, which comes from the sixth segment, giving it the name ophthalmic segment. Now, subtracting out the brain so that we can appreciate the branches of the internal carotid artery. So this is the one on the left, this is the one on the right. This is a bit of a graphical editing error on their part. So a bit of skull stuck to the ICA here. So very nice ICAs, those little branches that we will not name but are important. So you see it reaching out across the midline to communicate with the other side. So it's so tiny, Snell or other usual anatomy books will not mention them anymore. But you can see the importance of collaterals, right? So now we complete the picture. We say that the terminal segment or the final segment is that called the communicating segment. So around this area, floating nearby will be the optic nerve, and below it, the third nerve, as it goes into the sylvian fissure. So when it enters the sylvian fissure, we don't call it internal carotid artery anymore. We rename it as the middle cerebral artery. So here at the final segment or the communicating segment, we give off the artery that gives it its name, an artery that communicates with the basilar circulation. We call this artery that communicates with the basilar artery circulation the posterior communicating artery. So it communicates with the posterior cerebral circulation. So going back to the basic picture, we subtract out the brainstem, everything else. And then to orient you, that was the left ICA we were looking at earlier, looking at it from the front. So we're looking at the base of the brain here. That's your ICA. So as it bends to become the middle cerebral artery, before becoming the middle cerebral artery, it has to give off a branch as the terminal segment of the ICA to communicate with the vertebral basilar circulation over here. So this segment connects your ICA with the posterior cerebral artery over here. So in this particular specimen, it has a complete set, a pair of PCOMs, posterior communicating arteries, coming out to join with the PCAs over here. So more on that later. No, we'll revisit the posterior circulation later. So we're just introducing you gently to the anterior circulation. Of course, in the cadaver, it's not as nice as this. Okay, so here on an angiogram, you will see two blood vessels which go towards the back of the brain. A larger one that connects with an artery that comes from the basilar artery, the PCA here. And you have a smaller counterpart which seems to terminate into nothing over here. So that part which connects with the posterior cerebral artery is called the PCOM. And this other artery above it is called the anterior choroidal artery. So at least everything in the brain, the terminology more or less tells you what it does. So the anterior choroidal artery, we break down the terminology. So choroidal, meaning it supplies the choroid plexus and it's going up into the cerebral hemispheres. So it must be supplying the choroid plexus in the lateral ventricle. So anterior choroidal artery, which means there might be a counterpart posterior choroidal artery somewhere, but it's not as important as this one. Hence, the opportunity to name it here. So that terminal segment, also known as the communicating segment, also known as C7, is where you see these two branches. All right. So in some people, this PCOM never connects with the posterior cerebral artery. So in some people, they maintain that fetal arrangement. So it's something that's seen in the fetus that is not usually seen in adults because for some reason, the posterior cerebral artery of those persons without a PCA, their PCA actually arises from the ICA, meaning the posterior cerebral artery arises from the ICA. So more on that later. So here we have it now, reorienting you. This is the basilar artery. So we're looking at it from the side again. We're on the left side of the patient or the person. This is the posterior cerebral artery. This is the ICA here in front, and this is the PCOM that connects the two circulations. And this is the other one parallel to the one below it, but terminates into the lateral ventricles. Okay, so why is it so messy here? It is messy for a reason. So we already mentioned, the brain needs every single drop of blood it can get. So anywhere it can get a blood vessel from, it will. So you see all these little arteries branching out, sprouting out to supply the base of the cerebral hemispheres. You see the pattern is seen everywhere. There must be some perforating arteries sprouting over there to supply that base of the brain. All right, so many critical gray matter are found there. You've already met the diencephalon, and you will soon meet the basal ganglia when we return after the break from endocrinology. So again, anterior choroidal artery. So all the arteries here have sprouting little arteries, which we will not name at this time. So in an angiogram, we subtract out the skull and everything else so that we can see the pattern here. So highlighting for you in black. No? So I simulated an angiogram so that we see it now from a anterior-posterior point of view. So that's the ICA. Before it branches into its major branches here, it gives off those two little arteries. The major one, which joins with the vertebrovascular circulation, which is the PCA, and a smaller one that goes up into the lateral ventricles. So here we see the major branches, only two. It will split one smaller artery to supply everything in the midline, and one bigger artery, which actually is a continuation of the ICA. So we subtract everything out to highlight the ACA, the anterior cerebral artery, the smaller of the two end arteries that sprout out from the end of the ICA. So meaning it already bifurcated. So it branched the ACA and the MCA over here. Now, focusing on the ACA. So to orient you, we're looking at the patient or person face to face. This is a antero-posterior view. And these are the ICAs where we are the patient. So we're looking in front. So this is you. Your eyeballs are here in front. And the ICAs have looped and branched into the ACA here. So the ACA, or anterior cerebral artery, goes towards the midline to supply the front of the brain, hence anterior cerebrum. Now, this artery is neither going to the front nor the back. So, for lack of a better term, they called it the middle cerebral artery because it doesn't supply the back nor the front. It supplies something in the middle, hence the term middle cerebral artery. Now, looking at it from here first, you still see all those sprouting all over the place. And you see these major blood vessels branching and branching, looping over here. It tells you the importance of that area. Now, if you're comparing, if this is actually an angiogram of a patient, and you saw nothing here, but you saw the usual things here, what would that mean? It means no blood went into this area. So when it is no longer supplied by blood, that tells you something is wrong. It means there is a blockage somewhere before this blood vessels here. So that's your anterior choroidal artery. And the ICA becomes practically the MCA once it reaches the sylvian fissure. So the sylvian fissure is over here. Hence the term or the name changes, like street names change when you're moving from Pasig to Quezon City or anywhere else in the Philippines. So for some unknown reason, you like to change the street names once you cross the border. So the same thing happens here inside the cerebral arterial circulation. Now back to this. So this is the MCA. So it is initially a horizontal segment inside the sylvian fissure, and then it goes deep within the operculum. So this part is lying on top of the insula. So these two parts here. So this is the first portion of the MCA. This loopy portion is the M2 portion of the MCA. Zooming in some more, you see this penetrating arteries, so from a large blood vessel straight to a tiny blood vessel. Now, this arrangement, while it serves the brain a good purpose, is also a double-edged sword. So from a very high pressure area, you get these small arteries here. That's okay if your blood pressure is normal. But what if your blood pressure went sky high? These are going to burst. And when they burst, you get blood flowing outside of the blood vessel and collecting in the tofu-like grain substance. And that is a very bad thing. That is an intracerebral hemorrhage. So back to the angiogram. So based from anatomy, the ICA will branch into an anterior cerebral artery here. and a middle cerebral artery here. Two different destinations. One is the midline, one is the sylvian fissure over here. So it follows the shape of the sylvian fissure. That's the ICA, and the ophthalmic artery we mentioned earlier, entering the orbit to supply most of the eyeball and the retina and the optic nerve itself. So when you're looking at it en face or en face, if en face is the French way of pronouncing it, you do not usually see it because it's looking at you. So you see it en face. So very hard to see it unless you're looking at it from a lateral view. The anterior choroidal artery, we already mentioned earlier, it seems to stop abruptly over here. The middle cerebral artery deserves its own mini lecture because it is the most important artery you will ever have. It supplies everything here in the lateral part of your cerebral cortex. What's here? If you remember the cerebral cortex lecture, your language areas. If you're talking about the left middle cerebral artery, here along the insula and the operculum is the language areas of your brain. So if you imagine, suddenly this vessel disappeared, and clinically, meaning on examination of the person, they are unable to speak. It jives, because there's no blood flow to the language areas of the brain. Now, looking at it from a lateral view, you see here the anterior cerebral artery, and the middle cerebral artery is now harder to see because it becomes en face from your point of view. So it's inside the sylvian fissure. So if it is a CT scan or an MRI, you'll have to digitally subtract away the brain so that you can see the artery inside the sylvian fissure. So that horizontal segment, which is inside the sylvian fissure, and it has its penetrating arteries supplying the base of the brain, which happen to contain your basal ganglia and the internal capsule. So for such a very important area for your movements, it's such a precarious blood supply. Either a blood clot will lodge here, and when you lodge it here, you end up not supplying that area. So what happens? You get paralysis on that side of the body. You get weakness, a very bad kind of weakness, as in 0, if you want to rate it over 5. 0 over 5 rating, meaning no movement at all, because you destroy just a small chunk of brain that innervates a big area, meaning all your face, arm, and leg, right? Or it could be a tiny one. You just block one artery here. If you have uncontrolled blood pressure for a very long time, if you have high blood sugar uncontrolled for a very long time, clogging this up, then you can also get those tiny strokes, which are catastrophic because you lose movements on half of your body. So perforating arteries, we will name them the lateral striate, or striate. You will understand why it's called striate. This corresponds to the stripe of gray and white matter on the inside of the insula. So the internal capsule and the basal ganglia, which is alternating gray and white matter. So lenticulostriate. So again, this will refer to the lentiform, the lens-shaped gray matter on the inside, the basal ganglia. So we already showed you a digital 3D model. Here is a real specimen. And you will see this also in the plastinated brains and the formalinized brains. The blood vessels will always sprout into tinier branches. They may be destroyed, but you may see remnants of this on the cadaver brains. Tells you how every square millimeter of your brain is important. It needs a lot of blood supply. So to orient, this is the anterior cerebral artery. with its all penetrating arteries here. This is the MCA, M1 horizontal segment with its own relatively larger perforating arteries here. And everything else has perforating arteries as well. So this just explains why it is called the lenticular striate arteries. So the lentiform nucleus and the stripe of the internal capsule here. So the the corpus striatum, as I will explain in the basal ganglia lecture. So that's the M1 with its important perforating arteries. We call the lenticular striate arteries. So when you get to this part here, so exaggerated, it's actually a distorted picture. This is the insula over here. It's a lot bigger than this. So the insula has that loop of MCA on its surface known as the second segment. So the second segment of the MCA is a loop because it is covered up by the operculum over here. So that is the insular segment or the M2 segment or the Sylvian segment. To give you a clue where it is found, it's inside the Sylvian fissure, hidden by the opercular parts of the frontal, temporal, and a bit of parietal lobe. Now, once it exits and reappears here on the surface, it is now called the M3. So M3 is when it's above and around the Sylvian fissure. So it is in the cortex now. So it's cortical M3 segment. So the moment you see it on the outside, that's an M3 already. M2 you will not see unless you peek under the operculum to look at the insula. So once it exits as the M3, it will now spread to supply this whole area that you see here. So that is a large territory for such a middle cerebral artery territory. So a very big territory, meaning a middle cerebral artery stroke is very catastrophic, especially if it affects your dominant hemisphere over here. You knock out your motor cortex, your sensory cortex, and a bit of visual cortex, you get disabled. And not only that, you're unable to speak, you cannot understand anything at all. So important to keep that middle cerebral artery free of cholesterol. Hence, you'll be taught in LU4 the importance of controlling risk factors, high blood pressure, high sugar, high cholesterol, smoking, drinking, to avoid clogging up those arteries here. Let's not forget the high fat diet. Right, so this is a gross specimen. So if it's around the Sylvian fissure, these are called M3s. And once they're already around or beyond the Sylvian fissure, we now call it M4s. So the M4 segments are terminal segments. They are end arteries. So as I mentioned, it's the end. Once you reach here, if you clog it up here, there is no rescue anymore. Very little rescue blood supply from elsewhere if you hit these arteries here. So most of the cerebral cortex, especially the speech areas here, the motor areas here, the sensory areas here, all knocked out if you have an MCA blockage. Right, so that is a middle cerebral artery stroke. Now, back to the anterior cerebral artery, or ACA for short. So better seen if you're looking at it from the side, because it goes towards the midline, and you will see it follows the shape of the structures around that area. It will loop around to follow the shape of the corpus callosum. It will loop around to follow the shape of the cingulate gyrus. So it will supply everything in front, everything in the midline, up to a portion here that is shared with the posterior cerebral artery. Right, so concept of sharing, that sharing area, because it is supplied by two territories, once you get to the very end of those two arteries, that is the more precarious areas because parang natuturuan sila eh. O ikaw na bahala dyan. And ACA tells the PCA, ikaw na bahala dyan. So that strip of tissue, which is bahala na kayo dyan, bahala na sila sa buhay nila because if something happens, like your blood pressure drops down very low, not enough blood supply to the brain, those areas will be the first to suffer. So those are what we call the watersheds. I mean, just beyond the reach of the river over here. So look at it from a anteroposterior point of view, you will see it as a vertical artery in the midline of the brain. So when you see this kind of point of view, this POV, this is the candelabra view, meaning the candle holder. So you see a set of candles on the side and near the midline. So that is your anterior cerebral artery on one side and the other side. Note that there is a connection between the two. We are fortunate if we have this because blood can trickle down from the other side in any case that there is a blockage of the internal carotid artery here. Now, this is no longer an end artery, meaning if there's always a backdoor source of blood supply, that particular segment is no longer an end artery. So that will form part of a circle of arteries here, which are not end arteries. So the concept you will see in a very short while, the circle of Willis. So this is an arc of that circle of Willis. If this thing exists, which is the communicating artery between the two anterior cerebral arteries, or we call it the anterior communicating artery for short, or ACOM. So this segment of the ACA, which came out from the ICA, before it joins with the other counterpart on the other side via the ACOM, is called the pre-communicating segment, or A1 for short. So it is, you can afford to have a blockage here because there is a chance that the blood supply will come from the other side. If for some reason there's a cholesterol clogging up this particular segment here, there's always a rescue from the other side if that bridge exists. And if it even exists, sometimes it might be too small to provide any valuable blood supply if the clog is here. So A1 from the ICA up to the ACOM over here. So just illustrating, it has its own set of penetrating arteries. They're also called lenticulostrate arteries. So now to distinguish these ones from the ones from the MCA, if it's from the ACA, they are anterior lenticulostrate arteries. If it's from the middle cerebral artery, it's not middle lenticulostrate arteries. It's called lateral lenticulostrate arteries. So they will supply everything that is nearby. So gray matter in the basal ganglia and a bit of white matter there near the basal ganglia. Right? So in this cut section of the brain, axially cut brain, this is the anterior limb of that boomerang I showed you in the cortex lecture. The anterior limb of that boomerang, the anterior limb of the internal capsule, and the caudate nucleus over here. So introducing to you parts of the basal ganglia already, since they are supplied by the MCA and the ACA. So this part supplied by the ACA. So we follow it. So here it is a part of the circle of Willis. You can afford to have a blockage here until a certain point. So, sorry, this is an A2. So here you can afford some blockage, but once you're past that anterior communicating artery, the ACA now becomes an end artery. So end artery, it's the end. If you get a blockage here, automatically everything downstream does not receive blood anymore. unless there is some connectors from the outside, via the meningeal arteries. So the A2 is found here. It is right below the genu of the corpus callosum. So it follows that shape. No? So we start here at the genu, near the genu of the corpus callosum. So from the acom up to the genu before it splits into two branches. One that will go to supply the orbital gyri, the frontal pole over here. So orbitofrontal, and one that will supply the higher parts of the frontal lobe. So what happens when you have blockages here? So as I mentioned, we learned neurology stroke by stroke, literally, well, before the advent of imaging. So this area, the front part of the brain, you might not know what it does so much until you see a change in the behavior of that person who had a stroke in this area. They lose their inhibitions. They're no longer as civilized as they used to be. Or on the other hand, they might be quieter than they used to be. If they were quite talkative before, now they don't seem to want to talk anymore. They'll just answer one word for each question. So that's A2. Now, once you reach beyond the bend here of the corpus callosum, genu, so that is the time it follows the cingulate gyrus here and a bit of corpus callosum here. So that becomes the A3, another end artery, which may get some help from the posterior cerebral artery over here. So this is the A3 now. So the A3 is also known as the pericallosal artery. So what does it mean? Callosal, corpus callosum, which is this structure here. Peri means around. So it's the artery around the corpus callosum. That is A3. So it extends and lies on top of that cingulate gyrus over here, all the way near the parieto-occipital fissure here. So everything back here is supplied by the posterior cerebral artery. Everything here is supplied by the ACA. So now you have a watershed here, just beyond the reach of both arteries. In about half of people, as far as half of cadaver studies were concerned, there may be an extra accessory artery here. No? So it's not always present. That's the callosal marginal artery. So around the margins above the corpus callosum. Right? So that is the ACA. And we learn it stroke by stroke. So let's say you don't know anything about anatomy of the blood vessels, and we told you this is the anterior cerebral artery territory. So everything here in the midline, near the vertex of the brain, that is supplied by the ACA. So what would we find if they had this kind of a stroke? So the areas which lack blood supply will not function normally. So this happens to be the leg areas for movement and the leg areas as far as sensation is concerned, but maybe not so much of sensory most of the time. So usually the ACA strokes, we'd catch them, maybe they have leg weakness and only a bit of arm weakness, depending on how involved the arm areas are here in the medial aspect of the cerebral cortex. So now we leave the anterior circulation for a while to go to the posterior circulation. So I just put a overlay here just to hide the anterior circulation so that we can focus on the blood supply that is lying on top of the base of the pons over here. Now, looking at this picture, what does it supply? So it supplies the brainstem, so to the midbrain, to the pons, using the small perforating arteries here. And then they will encircle the brainstem because the brainstem is important. Your tegmentum is located over here posteriorly. So these blood vessels will encircle the brainstem. A pair of each will encircle the left and the right on the other side to supply everything at the back. No corners left unsupplied. Very important. It's very hard to stroke out the brainstem because of its paired blood supply. Very similar to the blood supply of the spinal cord. So, and then you get this big thing over here, which is an outgrowth of the brainstem and became a very sophisticated mini brain, the cerebellum. So as you can see, it also has a lot of blood supply. You have one coming up here superiorly. You have another one coming here. So one here between the midbrain and the pons, one here between the pons and the medulla, and one here just near the medulla coming from the vertebral artery. So what does this mean? It means those billions of brain cells you have in the cerebellum are important. Thus, they need to have a lot of backup blood supplies. So, but it's not perfect because they become end arteries the further they are from the other arteries. And then you have watersheds in between those arteries. So you have a superior cerebellar artery up here. And then you have one artery that supplies the front, bottom of the cerebellum, so anterior, inferior, and one supplying the inferior part of the cerebellum and most of the posterior part. So thus, that is why they were named. So now you have the superior cerebellar artery up here. You have the anterior inferior cerebellar artery down here. Oops. And we have the posterior inferior cerebellar artery over here. So we can call them PICA, ICA, and the SCA. So studying now the posterior circulation, okay, usually it is covered up by the vertebral column. So we need to do angiograms so we can visualize it better because ultrasound will not penetrate bone until a certain point. So the vertebral artery is inside the vertebral column here until it pierces the subarachnoid space. So once it does, it travels and follows the structures nearby to meet its counterpart from the other side. And once those two vertebral arteries meet, they will form the basilar artery here in the middle. Okay, so illustrating, it is protected here by the spine as your V2. So if you check its origins, it comes from the subclavian artery on the left side. So here also on the other side. Now, a variant that is common across everyone is that the right side is usually smaller. The right vertebral artery is usually smaller than the left for some reason. But regardless of the size, in this digital age where everyone's in front of the computer or looking down at their cell phones for a very long time, and in the elderly people who have been through a lot of things, carrying heavy loads, that spine may not be as perfect anymore in terms of its curvature. And you can imagine if you change the curve of the spine, you're altering the course of the vertebral artery. So it might be bending it too much in some individuals. So it might cause some problems. Or if you had a whiplash injury, or if you had a very aggressive masseuse, or if you're in a basketball game and you had to turn your head suddenly and then you happen to rip a bit of the wall of the vertebrals and then it forms a blood clot, which will cause a stroke. So very precarious while it's inside this part of the cerebral cortex. Pardon me while I plug in my laptop. I plug in my laptop before it dies. So any questions at this point? Is anyone out there?
I have a question actually, where parang very many topics ago na.
Yes.
I wanted to clarify yung kanina, medyo, ano yung sir yung the landmark between C5 and C6?
C5 and C6 of the carotid, you said?
Internal carotid, yes sir.
Okay. The C6 is the part which gives off the posterior communicating artery. The moment you see a posterior communicating artery, that is already a C6. So before that would be the C5.
Okay. Thank you, sir.
All right. So just to resume.
Doc, can I ask a question?
All right. So you see here the lateral view. So in this particular specimen drawn by this particular artist from Radiopedia, the spine that you see here is quite straightened, and it is quite accurate in the digital age, because most of your necks will already have some form of spasm of your muscles already from looking at the screen for hours or days. So you lose the normal C-shaped curvature of the spine here. So again, this is not good for your circulation. So sometimes we do a lot of tests to check out why a person has dizziness, until we check, meron palang naninigas yung neck muscles, no? Because your curvature of your spine is being compromised here. So sometimes the dizziness that you feel when you have a stiff neck, that may be part of the explanation. You're squeezing your vertebral arteries here within your vertebral foramen. All right, now going back to anatomy. So you see here, it's safe and at the same time precarious in its own canal until it reaches your C2 vertebra over here. Now, the moment that vertebral artery exits that vertebral foramina, it now loops here. That is now called the V3. So from a structure inside the spine, it is now outside of the skull, outside of the spine. You can also damage it here until it goes into the skull and penetrates the dura mater to go into the subarachnoid space. So it assumes this quite constant shape that you hear from a very straight structure. Suddenly it loops around the axis and then curves inwards because it has to avoid the pons here in front. So it makes a very bent course inside the intracranial compartment. All right. So for some unknown reason, a very important artery that supplies the spinal cord is very small. The anterior spinal artery is a branch of the vertebral arteries. And if you're fortunate enough during the leap or during the pre-leap of OS202, you will see a particular specimen where you will able to get out the entire spinal cord and its blood supply. And you will see what is left of the vertebral arteries, but you will see the anterior spinal artery down here. For such a small artery, it supplies such a big area of the spinal cord, the anterior spinal artery. Whereas your paired spinal artery are supplied by a pair. No, there are a pair of posterior spinal arteries for this smaller posterior 1/3 of the spinal cord. The reasons for which we are not quite clear on, considering how important the anterior 2/3 of the spinal cord is. Your motor functions are located here in the anterior horn. Your motor neuron cells are found here. So why it is so, we do not know. So that's just hopefully Dr. Bondong and Dr. Seng had shown you this picture of the aorta, the posterior spinal arteries which come in from the intercostal arteries here. So remember Adamkiewicz artery over here. But for some reason, they like to supply the posterior part, not the front. Anyway, back to the neuroanatomy. So what you see here, I superimposed my drawing on top of a picture from Nolte of the brainstem, just to prove a point or to show a point. The pattern that we will see consistently as to the circulation of the brainstem, it is that important that you have blood supply for the front and the back. But the problem is the source is just one big artery, the basilar artery. Now, depending on which part of brainstem you are in, you will still see this pattern. Always a pair of paramedian arteries which will penetrate, and a pair of circumferential arteries which will encircle and penetrate to supply the entire brainstem. Now, this is a medulla. So the butterfly-shaped medulla with the pyramid there at the bottom. Now, you can see the anterior spinal artery supplies a bit important structures. Again, why does such a small artery supply such important areas? It supplies the hypoglossal nucleus over here. It supplies the medial lemniscus down here, as well as the pyramid and a bit of olive. Now, how do we know these things even without a scan? Well, based on learnings from past patients who did not make it, no, before their demise, they were paralyzed. Before they expired, they had dizziness and they had numbness, and their tongue was not moving normally. So, breaking it to you gently, what you will see in people who have a stroke in this area, so we call it infarction, meaning no more blood supply for a good number of hours causes permanent damage here. You have weakness on one side, you have tongue weakness on the same side, opposite of the weakness, and over time the tongue shrivels on that side of the stroke. Again, introducing to this to you only now. Introduction and then practice, practice, practice before you can demonstrate it once you see a simulation patient or you see an actual patient with that kind of pattern. So weakness, numbness, a weakness of the arms and legs, and then weakness of the tongue, as well as some numbness on the other side of the body. You'll understand this as we go along to phase 2. So that's anterior spinal artery. Now, once you approach the union of the two vertebrals, before they join each other, the first of the 3 pairs of cerebellar arteries are given off, the pica. You can see it looping around here. So it has to supply first the brainstem before it can supply the cerebellum further on. So here, on looking at it from a lateral view, it loops around the medulla to supply the bottom surface and the back of the cerebellum, hence posterior inferior cerebellar artery. But in some cases, which can be missed if you're not aware of neuroanatomy when you're already practicing as physicians, it doesn't need to be a cerebellar stroke. If you have a pica problem, it can be just a stroke here in the medulla. Now, knowing the blood supply of the pica will allow you to explain what's going on, because sometimes these strokes are so small on the MRI itself, they might be missed by the radiologist and the neurologist who is looking at that patient if they were rushing or they downplayed the symptoms. Here we have an MRI. So this is a magnetic resonance imaging picture. It shows the flow of protons, mainly water. So wherever water goes, it is just gray. But the moment the water stops diffusing around, it is locked within this area because the sodium potassium pumps have failed. It lights up on this particular sequence of the MRI. So this is a pica stroke, sparing the cerebellum. So not included there in the name of the artery is it should be posterior inferior and dorsolateral medulla artery, but it's too long, so we just stick with pica. So this is the dorsolateral medulla. If you remember the rule of force, the SS are over here, dorsolaterally, which means sensation and a bit of sympathetic, autonomic, as from Dr. Wilson throughout this lecture earlier, may be affected. Or extreme dizziness because your vestibular nuclei are affected because they lose their blood supply. So sometimes it's just dizziness and nothing else. So they can be sent home and then later on they get a catastrophic stroke over this entire area because the diagnosis was missed. So a missed diagnosis. Again, introducing to you it now so that it becomes cemented for you as we go along, bridging it to LU4. So what is it? Why is it so? The pica encircles the medulla and supplies most of the dorsolateral medulla here. So remembering the four S's, you have two sensories up here, as well as the sympathetic closer here in the tegmentum. So you get spinocerebellar involvement, meaning the patient has difficulties walking. So again, I will return to you next year in LU4 and remind you of something here. So we're going back in time to tell you your dizzy patient, you should not have sent home because that patient who had dizziness, you did not test the gait, meaning you did not let that dizzy person walk in the BC emergency room. Okay, so something to remember, always make your patients walk if you're doing the neurological exam, so you do not miss something like this. So the two vertebral arteries will join now to form the basilar artery. Now the basilar artery, with that pattern of perforating and what do you call that? They encircle the brainstem to supply the brainstem, which means the brainstem is quite resistant usually to low oxygen, not enough blood supply, because a small structure with a very big blood supply here is assured of a relatively constant blood supply. The moment you get zero blood supply and then it becomes catastrophic, the patient goes into a coma. Or I'm not sure if you had the diving bell story yet. They become paralyzed, and they become like the person in the diving bell and the butterfly, because those tiny arteries which will supply the pons supply your motor fibers, which are dispersed there in the base of the pons. You have this enlarged artery here, which encircles the brainstem, but similar to the pica, because of its end distribution is the cerebellum, it is named as such. No? But if you had your way, and you wanted to be obsessive compulsive about the completeness of the name, you would call it anterior inferior cerebellar and dorsolateral pons supplying artery. But we just call it ICA for short. So what does the ICA do? It supplies the pons and the cerebellum's anterior inferior portions here. So ICA. Now, what's significant about the ICA? So it is a circumferential artery. So it supplies the dorsolateral pons. If you remember the rules of the brainstem, the four S's again is emphasized here. So not just the cerebellum, but the dorsolateral brainstem pons segment. So I put it in white here in case it is deprived of its blood supply. So then you have perforating arteries here. What happens if you remove that blood supply? So it now depends which parts of the brainstem lost their blood supply. Is it this area here with the motor fibers causing paralysis? Is it hitting the facial nerves nucleus here, which causing a Bell's palsy, which can be misdiagnosed if you did not do a examination of the cerebellar testing and motor testing? Okay, so what happens here? One of that role of the brainstem is that MLF, which was mentioned earlier, and I did not go much into detail, but I just said the MLF is the connector of the eyeballs. So if it so happens it was this perforating artery which lost its blood supply hitting that MLF, then your patient will have eyeballs that are not moving anymore in the same direction. So more on that when I lecture to you on the motor cranial nerves. You will see a repeat of this. Then finally, the last of the paired cerebellar arteries is the SCA, or the superior cerebellar artery. So as nicely drawn by this book's author, they converge, supply most of the cerebellar territories, but again, where they do not reach, that forms a watershed. So anytime you see a patient whose MRI findings do not seem to correspond to a arterial distribution, but seems to be in between, we call those watershed strokes, watershed infarctions, meaning they are beyond the reach of the artery supplying the area. Okay, I did mention a bit of this. I'm not sure if you caught it the last time. Between the superior cerebellar artery can sometimes strangulate the third nerve there. So if it so happens you have an anatomical variant and we all do not have the same configurations of our blood vessels, if you also happen to be unfortunate that your oculomotor nerve is squished, no, by the SCA and the posterior cerebral artery here, you might get a drooping eyelid on one side, or you may be cross-eyed because one eyeball is not moving anymore. This is a clue. No? If you're particularly young and you don't have any blood pressure problems, blood sugar problems, and you have that symptom, then we look at this. No? So this is something I learned years ago while reading the Neuroanatomy Made Ridiculously Simple book. So it stuck with me. So I'm sharing it with you now. Right. So just looking at the cerebellar arteries again, just to demonstrate the importance of the cerebellum as a newer addition to our armamentarium as humanoid species. The SCA, the ICA, and the PICA. Now, the end of the vertebrovascular arterial circulation is the branching, the bifurcation into the two posterior cerebral arteries. So as the name implies, posterior, sa likod ng utak, ugat. So this artery here, which supplies the back of the brain, so temporal and occipital and a bit of parietal, is your posterior cerebral artery. Highlighting here the PCOM, because if you have a very large PCOM and a bit of your PCA is missing, this entire PCOM becomes the posterior cerebral artery. It's one long artery coming from the anterior circulation, which may be an issue later on if you're unfortunate enough to have a large stroke here. The entire front temporal, parietal, occipital brain will lose blood supply, a major catastrophic hemispheric kind of stroke. So looking at it from the coronal view or the anteroposterior view, the final bifurcation of the vertebrovascular system are your PCAs, or posterior cerebral arteries. Now we make a designation because of certain common variants, unfortunately. that PCA, we now segment relative to that PCOM. Okay, why are we doing this? Why are we segmenting the PCA into a P1 and beyond the P1? Because sometimes the P1 never appears. Some of you may not have a P1 from birth, or it's too tiny to be of any use, such that the segment beyond it, which is the P2, arises from your ICA completely. No, a PCOM PCA variant where there is no P1, meaning the PCAs did not arise from the vertebrovascular system at all. They are anterior circulation arteries, which makes them end arteries. And as I like to repeat myself, end arteries that have a stroke, it's the end, no? Because there's no more blood flow rescue from anywhere else. But fortunately, some of you might have a P1 and a PCOM, which would give you an advantage, meaning if something happens to the P1, like a stroke, and you have a valid existing PCOM, you can get blood supply from the PCOM into the PCA P2 from the ICA. So you save yourself from a stroke in case this segment gets blocked. So hence the importance of segmenting the PCA into a P1 pre-communicating segment and a P2 post-communicating segment. We just call it P1 and P2 for short, but we know the implications of this segmentation. Now, what is important about the P1? When it exists, it supplies the midbrain. Now, hopefully some of this look familiar. This is the red nucleus. This is the cerebral peduncle, and the third nerve would be coming from around here to give rise to its fascicles here. So what is the importance of the P1? It supplies the midbrain in its entirety. Now, if you were born without P1, you would still have those arteries sprouting out from the P2 here to supply the midbrain. But then you're at a higher risk if you have cholesterol there. So very importance of a good, of a proper lifestyle that is not sedentary, and a balanced diet and enough exercise. Stroke is no joke, as they say. So if it so happens that this entire part strokes out, meaning there's no blood supply, and that's the thing about brainstem strokes, they appear disconcerting, no, to the average physician because you get so many abnormalities that we can't explain if you did not have a background in neuroanatomy, which is why you're here today. So if you infarct this, you'd be damaging a part of the motor system, and you'll be damaging what Dr. Baticalan would have discussed. No, there are certain cerebellar fibers from the superior cerebellar peduncle which cross in this area. So you get a weird, well, let's call it weird patient who does not present the way we were used to. It's not very common. They come in dizzy, they have cerebellar abnormalities, and they're also weak on one side. So knowing your neuroanatomy, you'd say, oh wait, baka brainstem yung stroke ng patient, baka nasa midbrain, especially if you have abnormalities in what the third nerve supplies, the pupils and most of the extraocular muscles. So that plus cerebellar findings plus motor findings, an astute LU3 student would say, sir, I think it's a PCA stroke. And you would be correct most of the time. So this is what happens. You get a stroke there if it's a catastrophic one. All right. So the P2 or the post-communicating segment now becomes an important end artery because it supplies certain areas now of the cerebral cortex. Now going back to the cerebrum slides I gave you before, these areas in the occipitotemporal areas are important for recognition of people's faces. Now, if it so happened that this P2 segment gets blocked, then everything it's supplied loses normal functions. So what did that P2 supply? It supplies perforating arteries to the thalamus. It supplies blood to the temporal lobe, to the occipital lobe, to the primary visual cortex inside. So what you expect would happen as an LU3 student with your rudimentary knowledge so far, okay, if there was a PCA stroke for some reason, they would lose functions in terms of vision of one personal body space. Okay. You would have numbness because sensory information is no longer relayed properly by a non-functioning thalamus. So that those perforating arteries, since they supply the lateral geniculate and the medial geniculate, well, mostly lateral geniculate nuclei of the thalamus, these are called thalamogeniculate arteries. So you can get strokes here, small ones or big ones if it's the major artery involved. Now, here what we call the cortical branches in the cortex supply the temporal and occipital areas on the medial half of the temporal lobe to distinguish it from this side, which is supplied by the middle cerebral artery, which tells you if this is MCA territory and this is PCA territory, then this area is a border zone. So a border zone meaning a watershed area. Anyway, if this whole chunk here loses blood supply, then the person would present with abnormalities in terms of vision. They will no longer see something on the other personal body space. They will not feel anything on that personal body space, and they will ignore anything on that personal body space. And at the same time, they don't recognize you if you do not talk because they cannot recognize your face anymore. So learning from stroke by stroke, we learn that if a person had a stroke here, there will be some kind of problem with their senses in terms of feeling anything, seeing anything, and recognizing someone's face. So more on that term when you get to phase 2, that's what we call phase blindness, which is a function of your fusiform gyrus over here. All right. So we learn stroke by stroke. So in the era before MRIs, we have these CT scans left and right. So when we see this pattern, it is not a middle cerebral artery pattern. It is a pattern of a PCA stroke, meaning it's the medial half of the temporal and occipital lobes down here. And as we go to a higher slice of the brain, we see that the thalamus also lost its blood supply and a bit of the internal capsule as well, which tells you some blood supplies are bigger than others. This particular person's PCA was particularly dominant because it involved also the internal capsule, which is traditionally supplied by the middle and anterior cerebral arteries. So this one you will probably find useful when you encounter people with CT scans in your private practice. This is also a way of showing you the blood supplies to differentiate a middle cerebral artery in yellow here versus a posterior cerebral artery over here in green. So taking note that sometimes, since not everyone is the same, their territories will not be the same as well. And sometimes someone's PCA is particularly dominant and overlaps more of the other territories. But this is the one that is classical. So another thing to take home from these pictures is the borders. No? So It can be missed on certain people, with certain radiologists or certain practitioners. You just see, oh, there's some dark spots in these areas. Oh, this person had very low blood pressure earlier due to a stab wound. And they, okay, never mind. But and if you remember, if this somehow penetrates your long-term memories, then you'd say, oh, I think we need a neurological consult for this person kasi meron siyang watershed or border zone lesions, which are most likely loss of blood supply. Zooming in, no? So classically, when you're looking at the subcortical brain, this is how it's all parceled out. So you have posterior supplied by the PCA, you have the middle supplied by the MCA's penetrators, and anteriorly supplied by the penetrators of the anterior cerebral artery. So this one is, like I said, anything you see in pictures, anything you see in atlases are all averaged out. So this is what usually would be, but take note that there will be variations on this. Okay, so now we see that there is actually a circle formed by the segments that we were emphasizing earlier. We were emphasizing the A1s. We were emphasizing the existence of an ACOM. We were emphasizing the existence of a PCOM. And the final picture needs the P1s. This creates a circle known as the circle of Willis, meaning if anything happens within the circle, there will be a backup blood supply elsewhere. Like if you cut the blood supply here on the A1, but you had intact PCOMs and an ACOM here, there's a way of getting around the blockage. Blood supply would come from here to supply that further downstream. But if you cut it here in the ICA terminal segment, that is not part of the circle of Willis yet. No? But technically, the circle of Willis involves the A1s, the ACOMs, and the PCOMs and the P1s. If you hit it here, a bit harder to get blood supply there unless you have working A1s and PCOMs here. The reason why we call anything beyond the circle of Willis is end arteries, and I always ask this in every exam in every year. So is this an end artery or not? Yes, because it's beyond the circle of Willis. Is the A2 an end artery? Yes, because it is beyond the circle of Willis. Is the M1 an end artery? Yes, a very critical one. And it is also beyond the circle of Willis. Is a P2 an end artery? Yes, it is. But is a P1 an end artery? No, it is not. So remember the components of the circle of Willis. These are not end arteries, meaning there is always a chance of backup blood supply from elsewhere. So that is complete. And unfortunately, that is not seen in everyone. So in usual, the average person, it's either too tiny if you have an acute stroke right now, right this moment, that artery did not have enough time to grow in size. No chance at all to enlarge as a way of compensating. But if it is over a long time ago, like your internal carotid artery actually is blocked 100%, but in the neck, there is still a chance for some blood supply to come in from other sources. Okay, so take note, there's always variations in these segments here. Okay, unfortunately, only 1/4 of people will have complete circles of Willis. Most of you might have absent PCOMs. One or both will not be present or too tiny to be of any use. The A1 might be missing or absent. Another variant is the P1 may be absent or both P1s may be absent, meaning your entire cerebrums are supplied by ICAs, which makes it a disaster if you have a major stroke in these areas. So the branches are also a source of problems if you smoke. So if you're smoking, stop smoking. If you don't smoke, don't start. Because these areas where the blood vessels branch out are weak points. They're okay if your blood pressure is normal. Uh, If it happens you have a genetic problem where the walls are quite delicate, they can tear on their own and form aneurysms. But in most of the time, if you're a smoker and you happen to be a woman and you have a family history of aneurysms, you better stop smoking and you better get your blood pressures checked to avoid forming this acquired problems later on. So they are acquired because in most of the time it's due to smoking plus blood pressure plus genetics to get these aneurysms, which are outpouchings of your walls of your blood vessels over time due to elevated blood pressure. So anywhere where there is a fork, no, a bifurcation, it is a possible site where you can form aneurysms. And the way you would catch them, if you see them when you do the neurologic exam, depends on the location. Like if it's here in the posterior communicating artery, in its junction with the ICA or the PCA, they can press on this third nerve over here. Otherwise, without warning at all, you get a sudden loss of consciousness and then you drop to the floor because of a very, very bad headache. You need to rule out an aneurysm. Okay, so this is an angiogram now. More or less, you know what certain arteries are based on anatomy. You know that this is a lateral view and this is a coronal view. All right? So I'll just flash down here showing you those circle of Willis variants. And then we get to the veins. So what's important about the veins? The sinuses, because you need important that you get drainage of the blood away. So with the little time you have, you can just go for your lunch and or relax and just listen as I go through the venous system because most med schools won't go past some of what you see on the screen. So important to remember, the drainage of your brain is through the jugular veins, internal jugular veins. They are important, as I will show you in succeeding lectures, in regulating how much pressure is inside your cranial cavity. So your brain does a very good job of keeping you alive most of the time. So usually when we do angiograms, the usual classic angiograms where we inject iodinated substance into the arteries, this will go into the capillaries and towards the end goes into the veins. Most of the time, the the radiologist or whoever's in charge will not print out anymore what happens in the veins, no, unless we request for it. So very rarely will you see images like these. But they are important if you're a woman who's taking pills, if you have blood abnormality that makes you clot more than the rest of other people, then you need to take note of the venous anatomy. So it's all about drainage. So the cerebral hemisphere, since it receives a bulk of the blood, also needs to drain a bulk of its blood. So in the cortex, most of it will drain into this large sinus hidden inside the meninges. That is the sinus that is in the midline, and you see it on a sagittal view, and it is located above. Therefore, superior sagittal sinus, which happens to be the largest one, can't miss it. Sometimes the pacchionian granules can indent on it and look like artifacts. Think, oh, baka may blockage siya. Yung pala, it's just pacchionian granules indenting into the venous sinus. So this is a venogram. So it's that large elongated structure up here. You cannot miss it. If you see a pointer here, most likely we're pointing at the superior sagittal sinus. If you look at all these vessels draining into it, these are the cerebral veins draining into the superior sagittal sinus. Next, a smaller counterpart also along the ridge of the meninges here is the inferior sagittal sinus. So it is like a mini superior sagittal sinus. It is small and also follows the same course, but it is a lot smaller and sometimes neglected when we're looking at venous anatomy. So what is its feature? You find it on the edge of the falx cerebri of the meninges. This one, a source of comfort. No, if you really have zero idea of venous anatomy, a source of comfort. Okay, if you cannot find the superior sagittal sinus, then you look for something straight. No, it's straight and diagonal, coming from the back of the skull here. So that is the straight sinus. So it's easy to name, straight sinus. So it is a vein, therefore the flow of blood will be going downwards. So everything is going to the midline and going downwards. So the inferior sagittal sinus here drains into that straight sinus. So obviously, there's nowhere else for it to go here in front. It goes backwards and downwards into the straight sinus. Here we have another vein, also in the midline and quite large. So the difference between this vein of Galen and the inferior sagittal sinus is the curvature here. So it follows the bend of the cerebellar tentorium. So that's the great vein of Galen. So it also drains into the straight sinus. So it is a vein, meaning it drains another thing. So if this is if we're lost, we look for the straight sinus and we follow it and we see the curve of the vein of Galen. So it drains what should be the inferior sagittal sinus up here, and it drains everything in front of it. So we see these veins here. We will get to that in a while. So just remember the configuration. It's like sungkit, no? If sungkit for getting fruits from the tree. So in children, unfortunately, you can also get aneurysms. This has totally nothing to do with smoking or genetics. It's just that they have very giant looking veins of Galen. So they like this. How do we know it's a vein of Galen? By the location. So it's an aneurysm of the vein involving the straight sinus here. So back to the normal. So the vein of Galen drains something. So not only just the inferior sagittal sinus there, it will also receive blood from a counterpart of the ICA. No, just know that for veins, they're a very weaker counterpart of the arteries. So yeah, drain two internal cerebral veins. So again, not very easy to see. It's usually the vein of Galen and the straight sinus that provide comfort. So if it is relatively straight and it's not following the falx, it is the internal cerebral vein, and they are a pair in the midline. So what they drain is everything inside. So mostly corpus callosum, mostly things in the midline over here. This one is called the vein or the basal vein of Rosenthal. How do we recognize it? It follows the course of the PCAs and the basilar artery. So counterpart of the basal artery is this small basal vein of Rosenthal. So a counterpart and a much, much weaker counterpart of the basilar and the PCAs. And you'll find them following the shape of the PCA on certain views. But of all the sinuses I have mentioned so far, it's okay to stop here, no, with the vein of Galen and this large sagittal sinuses here. The basal vein of Rosenthal may not be that recognizable to you unless you really look for it. So over here is the basal vein of Rosenthal. In opposite to a basilar and posterior cerebral artery, which is found here in the middle and branching out, this one goes posteriorly because it's really aiming for the vein of Galen and the straight sinus here. So these are just nice colored dissections of those venous drainages. So what can we recognize? Look for the straight sinus. And where you can find the straight sinus, you will find the vein of Galen. And hidden in the falx cerebri will be the inferior sagittal sinus. And here, hugging the pineal gland and the thalamus would be your internal cerebral veins. The basal vein will be aiming for the brainstem. So everything up here aims for the cerebral cortex. Right? So this is just a diagram to remember the configurations of the sinuses. So wherever they may be, they'll all end up here in the confluence. The confluence just means where everything comes together, or called the torcula. So here, important if you'll be an ENT or ORL, no, otorhinolaryngologist, would be this transverse sinus and sigmoid sinus. Why is it important to ENTs? It is really right there close to the petrous bones of the temporal lobe where they do their drilling and digging around for the abscesses inside the inner ear. You do not want to destroy this, or any infection in this area will actually inflame this transverse sinus over here. Okay, transverse sinus. Where does it go after the transverse sinus? It will drain into the internal jugular vein. So from this transverse sinus, which is located on either side, on the sides of the skull, they will now drain into the internal jugular veins via the letter S-shaped sigmoid sinus. Okay, so variants, if we all had small right vertebral arteries, in a majority on the venous side, the right transverse sinus is usually bigger than the left. So majority of your venous supply goes into your right transverse sinus. Okay, and that is the cavernous sinus that we have been mentioning again and again in the cranial nerves and in the part about the ICAs. Why is it there? Because it's very central and it's a venous structure, meaning it drains things. So veins must drain. If they do not drain, that causes a problem. And if it is a drain, like any drain, uh, what it drains is important. So that centrally located cavernous sinus drains your orbits and drains a bit of your maxilla and your maybe your teeth down here. No? Also, it also joins with the drainages on the outside. So now you have a back door into the brain. Or if you remember the blood-brain barrier, it is well protected, but the venous system is a back door, especially if the source is coming from what we're not expecting, which is right here in front. Let's say you had a pimple here in what we call the danger triangle of the face. You're a doctor pimple popper and you're not very sterile when you did your pimple popping. Your pimple got infected. Everything drains somewhere. So that pimple that you pop that got infected will drain the bacteria together with it here into the cavernous sinus. And if that gets infected, it gets inflamed, the blood clots inside, and then everything it drains starts to swell. So you get swelling in the face, everything looks red, everything is swollen in the face, aside from that pimple that you popped. So you will learn about that as you go into upper years, when you got an infection in the cavernous sinus. Right? Why is it important? Because it is there. And because it is there, and because of the things it contains, then it becomes a problem in some situations. Because if you have pus, or if you have blood clots forming there because of the infection, then everything that's inside will be damay-damay na. No? Your cranial nerves will be inflamed, so they will not perform what they will usually be performing. So you'll find some abnormalities when you test for the cranial nerves. The sphenoid sinus is there. So if you have sinusitis which became infected, and then somehow it eroded into the cavernous sinus, then that will cause the same thing. The drainage of blood will be affected, and infection will take place. Right? So it connects with your face via these ophthalmic veins. And the problem here is its connection with the veins on the inside of your brain, which can be a problem. That means your infection can now break through your blood-brain barrier and affect your brain. So something we want to avoid. Okay, this just illustrates for you why we have to be careful with our faces, why skincare is important, and why having a proper hygiene is important. You don't want that to happen. You don't want your cavernous sinus to be inflamed and infected. Your teeth as well are important, since it can also, your bacteria there can enter via this back door as well. Because there are no valves in the veins of the brain. You can come in and come out as you please. It's just the direction of flow that pushes you out. Right? So never mind this. This just shows you the connections of that cavernous sinus with those sinuses at the back. So from face to back, it's all interconnected. Okay, so these are just variants. I'll just flash through these. At your level, you don't need to stress so much about these. It's just to tell you it's all connected. And this is a back door. All right, so more or less, you might need to come and go and repeat through some of the slides here. You can repeat and rewind certain portions of these parts of this lecture, so you can get what we are talking about and why the veins are important. So these ones are higher level already. I just included it here. You can disregard these. These were supposed to be hidden, but they're still showing on screen. All right. So that's just the venous drainage of the posterior fossa. They still drain into those major sinuses up there. Right. So some of these we just breeze through. That's the superficial middle cerebral vein I was mentioning, which happens to connect the sinuses with your cavernous sinus. And you have these anastomotic veins. They're here for completion's sake. Maybe if you're a neurosurgeon, you might want to revisit this. You have connections, unfortunately, with that cavernous sinus. No? Your vein of Trollard up here, and the vein of Labi over here. So things that you do not see in the lab because they're all collapsed already, or they may have been destroyed in the extraction of the brains. All right. So the reason why I was emphasizing strokes is because tomorrow is World Stroke Day. So kahit papaano, you have some minimal knowledge of what's going on, and you see the importance of your blood supply in your brain. So thank you very much.
Thank you, Doc.
Thank you, Doc.
Salamat po, Doc.
Thank you, Doc.
Thank you very much. And see
Thank
you
you,
after
Doc.
the long weekend.
Thank you, Doc.